All right, welcome back to another Owens Recovery Science podcast. Kyle, I'm freaking so excited
What's
about this
happening?
guest today. Normally, I
I know.
shoot the crap with Kyle, make fun of him. There's plenty I can do to
Yeah.
make fun of
We're not
him.
going to make fun of me
Uh,
today.
Although we will as the
I get
podcast
off the
goes
hook.
on, but I
Oh,
don't I don't want to I don't want to like take too much time because there's so much I can make fun of you on right now. So, but I do want to jump into this because this guest we have on here, she kind of changed the way I thought about BFR when we first started talking.
Mhm.
Because I'm an ortho sportsy guy and it was all muscle, muscle, muscle. We was always getting these questions about neurologic populations, and I was like, sure, yeah, neurologic populations, muscle,
They
muscle,
have
muscle.
muscle.
Yeah, but then she starts talking about things, and I'm like, I have no idea what you were talking about with some of this stuff. And so she's extremely smart. She's super passionate with the population that she works with, and I'll let her kind of go deeper into this. She's also a movie star. She has an IMDb page that I saw as well. She's on Amazon Prime. I saw that I can download
Yeah.
seasons of
Oh,
this.
really?
Yeah, yeah, I'm gonna get
Nice.
it,
I'm
man.
checking
So
that
she
out
can
now. I
feel.
didn't know that.
I so I have an IMDb. Did you know that, Kyle?
I did know that, but it doesn't have your
Yeah. Oh,
picture.
I've
I've
said that a
looked it
lot of
up.
times, huh? Annie, I did 60 Minutes years ago, and I was on it for like 5 seconds. And I was trying to find the clip of that, and there's an IMDb, and it says like Johnny Owens, and it had my two lines I said in that thing. So it's the worst IMDb of all time. I need to see if they can take it down.
I'll be sure when I edit the video to splice in your IMDb, and then we'll cover it up with Annie's.
Yeah,
Um,
yeah, to crush me
the
with.
BFR, the
Yeah, she has like
IMDb
seasons and
BFR
stuff
people.
like that. Well,
Yeah.
cool. And so years ago, she started this, and we'll go into kind of her background for sure. And then this crazy thing called COVID hit, and it kind of, I'm sure, slowed things down. But this is 2019. But I was able to get her dissertation deck from her as she was finishing up her PhD, and I was going through it last night. And her final slide was this. And so this is why I think research is so badass, and what we do can be badass. So she had quotes, the most important outcomes, as her final slide on this from her subjects that were in this study. And the first one was, I have hope now for the first time in 18 years, was one subject. This exercise saved my life. If it weren't for y'all doing these studies, I wouldn't be here. I really do believe that. The thing I notice more than anything is that I can sleep better when I do this. That's a really big deal for a person with my disease. I notice that little things like opening a jar aren't hard anymore. You guys have no idea what you've added to my life. I'm so sad this journey is over, and I hope we can do it more. I have not felt this good in a really long time. So, Dr. Annie Bane, you're a
Wow.
badass. Look at that, touching lives. She's
Incredible.
smart. She's a movie star. So, anyways, Annie Bane, Dr. Annie Bane, how are you?
Good, thank you. Thank you for having me on here. And it has been a long time coming, and I'm just so grateful that the research is finally out. And like you said, that's the most important outcomes for the ones that like you said, Kyle, you can't publish in a paper, but the
Yeah.
quality of life stuff, and that doesn't come from a survey. It's the things that people tell you, and it really, we kept doing, I couldn't stomach the idea of research being over and not seeing these people anymore. So we were able to bring them back in the lab and have our lab workers and student volunteers continue to work with these individuals. And we're still doing that today because of the exact reason. It makes a huge difference in their life. And I've not seen exercise be more effective for a specific disease than for Parkinson's disease. So
Yeah.
it is whenever our folks stop moving, they don't live a long time. And it breaks my heart to say that because there are a handful of individuals who, because of COVID, really, they stopped coming in, interacting with people, and they were sedentary, and they're not here anymore because they weren't moving. And it's just it can be such a cruel disease, but also I have a lot of hope for people who have been diagnosed. And there are things that we have to do, and we have to be innovative and creative because there's not a cookie cutter exercise program out there that's going to be incredibly effective. We have to think through the physiology behind the disease and and come up with something innovative. And I think that's really what BFR helped me to do and me to see is we can get around some of these major obstacles that present themselves to people with Parkinson's and be really effective with various exercise protocols.
And it's so valuable to you, not just BFR, but exercise in general. But can you touch on this outreach program you set up? You're not at Baylor or Hardin-Simmons in Abilene anymore, but
Right.
tell us about that outreach.
Right. So I was at my PhD was from Baylor, and then I was a professor at Abilene Christian University. And we actually did two different studies with Parkinson's. The first was not BFR, it was a resistance training with instability. And it was more of a pilot study. And then whenever my dissertation, I really wanted, I noticed this major vascular disruption with people with Parkinson's disease. So I tried to find an exercise protocol that I thought would be very effective for improving the vasculature of someone with Parkinson's. And it opened this whole gate of I could just keep going on and on and on. But it opened this whole gate of this problem of autonomic dysfunction. And so BFR presented the best possible in such a short period of time. It was only 4 weeks. So we did this study. We conducted it. We saw some really great measures, and then COVID hit. Like you were saying, we didn't see a lot of our people for quite a while. We couldn't have anyone in the lab. We couldn't even do physiology labs where I was teaching at Abilene Christian University. So whenever everything kind of cleared and we were able to have individuals back in, we opened the outreach program. And a lot of the people that we worked with through the two studies, they had lost. There was one lady, she lost, it was about 50 pounds, and we did a DEXA scan on her, and 40 of those pounds were from muscle and bone. And it was so sad. It was heartbreaking. So we were able to get her going again, and really she was just a fighter. That's all of the people I work with. They're fighters. They work, their body fails them every day, and they choose to get up and come to our program, and it's all free of charge, and everything's individual, it's customized, it's periodized. So I call it periodization for Parkinson's. And we have, I no longer work at Abilene Christian University, but I moved everybody over to Hardin-Simmons University and have a amazing group that helps with that program. So I know Hardin-Simmons is
alma
awesome.
mater, baby.
That's right. Yeah, such a good university. And so I still write all of the programs for the people with Parkinson's, and we have student volunteers and physical therapists, and so we evaluate, and then we write exercise programs, and we have about 40 people, which Abilene's not the biggest city in the world. So 40 people is a lot. We've really tapped into a big part of the Parkinson's community, and I have a whole team behind me. It's not just me who has done this. So I'm so grateful for everybody and their hearts. Really, that's why anyone is helping with it, because they have the heart for the people with Parkinson's, and it's a huge difference maker.
Maybe when we get done, we can get contact info or any website or anything we can put in the show notes if people in that area want to reach out.
Awesome.
And get connected. That would be cool. So
Yeah.
you're not a physical therapist. You're a physiologist in nutrition. Can you give us a little bit of your background of what drew you into those fields, and then Parkinson's specifically?
Yeah, so undergrad, I was at Abilene Christian University, and I was accepted into PT school at several different places. And the day before orientation,
Show off.
I accepted to Hardin-Simmons. The day before orientation, I don't know, I had this overwhelming, well, I had been thinking it, but I thought, oh gosh, I don't know if I can do this. I don't know. I ended up withdrawing. And it was a really tough time to go talk to Dr. O'Connell about. Yeah,
I can't imagine.
Yeah, she was very gracious, but it still gives me, my heart rate's up at, above 100 right now.
She's one of those people, you're so terrified of her when you're young and inexperienced, but then when you get to know her, she's the greatest. She's so awesome. Yeah.
Right. Yes, she was she gave me a hard time at first, and then she was so gracious. And
sure.
I don't really understand that exactly why that happened, but a guy who applied 6 years in a row got my position. So
Oh,
they
there you
called
go.
down the list, the wait list.
Wow.
And so I'm like, okay, maybe I was the placeholder for him, but
It
I
was
went
me. It
to
was
work.
me.
Yeah, I was
Yeah.
gonna say, was that Kyle?
I went to North Texas to the Osteopathic Research Center, and my sister was in medical school at the time, so I did osteopathic research, and I was the person who entered the data, and I just kind of got the behind scenes about what research was, and I really loved it. So then I went and got my master's at Baylor. And then my husband and I, we're high school sweethearts, so we had dated since we were 15. And he finally asked me to marry him. So we got married, and we started a gym called 3V Health and Fitness, worst name ever, in Waco. And then about a year into the gym, I thought I'd missed school. I want to do more. So I applied for the PhD program at Baylor. So we ran a gym, and I was started my PhD at Baylor. And then fast forward, I took the Abilene Christian professor job, ABD, which don't ever do that if you're listening to this. Don't ever do ABD, just finish it. Don't jump the gun. But I just had my son at the time, and went and taught at Abilene Christian University. And then I was able to finally I had a few proposals and they were rejected, but finally, because I wanted to do Parkinson's research. And the reason that is because when I went to ACU, everything works out for a reason, but the best professor I had, the most amazing professor at Abilene Christian University, she was teaching, we overlapped years teaching just for a little bit, but she was diagnosed with Parkinson's disease. And she didn't tell anyone for years. And I noticed she would hold her arm by her side when she would walk. She'd kind of, grasp her thigh when she would walk. And if she was holding keys, she would, twitch like this. And but she didn't tell anyone. She finally told me, and she's such a go-getter. And she said, we have to do Parkinson's research. And I said, I do vascular research at Baylor, postmenopausal, postprandial, chronic kidney disease. Did some intermittent fasting stuff, but I don't do Parkinson's. She's like, it doesn't matter. We need to do it. There's no resources in Abilene for us. We have to do it. And so I went and proposed, let me do this as my dissertation project, and I got shot down. So we did a project anyway. And then finally there was a switch in my chair, and he said, yeah, let's do it. And then blood flow restriction came up, and it was just, but what I noticed from the first study is purple hands. So we did this resistance training with instability, and I would take blood pressure, and their hands were so cold. When they would do this, just a 6-minute walk, which is a, fragility test walk for older individuals, and we would just do a 6-minute walk. They would sit down, and I would take their blood pressure. Their hands were purple, and they were so cold. And I'd done a lot of research before, and I'd never experienced this. So that's where I realized something's not right with blood flow. There's something going on
Yeah.
in the arms and then in the legs too. So anyway, that's how kind of my whole journey happened with being at ACU, and then my mentor and most amazing person in the world has Parkinson's, and really spiraled me into doing this Parkinson's research.
And so you have an amazing picture in that slide deck too of, I don't know if it's one of your subjects or what, but the purple hands. It is purple. I mean, you can look at it and just say there's something vascular that is happening here with these individuals. So can you, maybe give an overview of Parkinson's? I think all of us really have the idea of the motor issues, but the autonomic dysfunction, vascular, orthostatic hypotension. We got about 2 hours of time to hit on all of those.
I know it's so much. And
Yeah.
cut me off if I just keep going. Just
No, it's good.
interrupt me. But Parkinson's disease is where your dopaminergic receptors in your brain start to die off, and they don't exactly know why. They're trying to figure out what exposure, you may have had at some point in your life that causes this to happen. But there's the substantia nigra part of your brain where this happens. And then you start to see symptoms that are classic of what individuals think of with Parkinson's disease, like the tremors are very, very, very common. Rigidity, bradykinesia, which is slow movements. A lot of falls start to happen too. Sometimes people fall a ton and then they're evaluated and it's like, oh yeah, you have Parkinson's disease. But pretty much you typically start to see it on one side and then it starts on the other side. So you may see that slight tremor in your right hand, and then all of a sudden your right leg is affected, and then your left hand and your left leg are affected. And your body just doesn't move the way that it is supposed to. There's freezing gait. So a lot of people fall because their feet just, they think they're taking a step and their feet just don't react and move. And so they fall forward. There's a lot of pivotal changes too, whenever you go to change directions and your body's going, but your feet are not moving. So these falls are one of the biggest problems with people with Parkinson's disease is, you don't, if you, physical therapists especially, you try to prevent falls at all costs because you know what it does cost you and how much the healthcare industry and it is astronomical how much falls affect individuals. So the goal is to really try to help these motor patterns and to try to make the body react and move the way that it's supposed to. Your brain's telling you your body to do something and it's just not happening. So these motor symptoms have been the highlight of most of the literature, especially in the world of exercise and exercise physiology. So that's really what the first study that we did, more of a pilot, pretty small sample size, is let's try to improve these motor symptoms. And we did. But the purple hands thing, that's what really bothered me. So then I started to look at something called autonomic dysfunction. So you have your autonomic nervous system and you have your sympathetic and your parasympathetic nervous system. So sympathetic is what you move to whenever you're exercising. And then you come back down off of that and you go into the parasympathetic, the rest and digest. So there's fight or flight, if you need to respond to a stressor situation, which exercise is a stressor. It should be a stressor. If not, you can't call it exercise.
And you say that, you repeat that multiple times today, Annie. That's perfect.
Yeah, so
we love
Johnny,
that.
at your when I went to the training in Miami, it was, a huge literature review and I loved every second of it because I just, I soak all that stuff in. But you said a lot of you talking about mostly physical therapists waste your clients' time because you're not pushing them hard enough. You think doing a little bit of band work is going to be effective and it's not. So, and from that, I thought you really, no, it doesn't matter if someone has Parkinson's and they're frail. We need to physiologically disrupt the body. And that's what BFR helps to do, that physiological disruption. So I do, yeah, that's what I tell a lot of people. And they're like, well, I walk around the block. I'm like, nope, you're not going to see a change. I mean, I'm glad you do that. But if you expect to get a lot better, that's not going to do it. It may prevent you from getting way worse, but no. So physiological disruption. Yeah, I remember you saying that, Johnny, in your seminar. So that was awesome. So with Parkinson's disease, this autonomic dysfunction, you have very low heart rate variability. So heart rate variability, it means, I basically think of it like how ready is your body to respond to a stressor. So if you stay very heightened and you're more sympathetic all day long, then whenever you actually are exposed to a stressor, you don't respond. But you never actually get down into that parasympathetic nervous system. So when you measure heart rate variability, it's very low. You don't have a lot of variation between basically the beats in your heart. And that's a bad thing. So when you have low heart rate variability, it means that there's something wrong with the nervous system. Something's not right. So people who are chronically stressed, have some sort of chronic disease, it can be, it's been studied, heart rate variability now with any sort of disease pattern, immunity, all sorts of things. So people with Parkinson's disease have very low heart rate variability, and that's been established. But I think what has not, the door has not been open to how this affects the vascular system. And this is where the purple hands come in. So whenever there's this communication, this crosstalk where neurotransmitters are supposed to talk with the endothelial cells. So endothelial cells are kind of the local cells that you have, within your legs. And whenever you need to vasodilate or vasoconstrict, they are the local cells that make that happen. But your neurotransmitters are supposed to communicate to make that happen as well. And this crosstalk is disrupted. So not only do you have those motor symptom disruptions, now when you're laying down, your blood pressure is really high, which should not be. That's the exact opposite as you and I would have. And now when you're standing up, your blood pressure is very low. So, and when I started to look at this, I have so many people out of those 40 people that I've worked with, so many that have had horrible falls because they passed out, not because of freezing gait.
Yeah,
I mean, which is still an issue, but they're passing out and they're free falling onto a bathroom counter
corner of a table
and getting a thoracic, and they have literally punctured lungs. They have, it is, but that's a free fall. That's not a stumble. And, falls, you guys have seen falls, they happen slow. But if you are passing out and falling, it happens fast. So there are so many people that just in the Abilene community that have these passing out falls, and they don't know to describe them. They're like, kind of, I'm not sure what happened, and further investigation isn't done, and no one really understands that these really bad falls, a lot of them are passing out. So when you're standing up, it's really low, you feel really lightheaded. It's that orthostatic hypotension, and this is so prevalent. I'm pretty sure it's 31 out of our 38 people in the study had orthostatic hypotension.
Yeah, that's what
I
said. Yeah.
So high, but there are studies that say about 65%, give or take a little bit, of people with Parkinson's have this. So that the crosstalk where my neurotransmitters say, uh-oh, your blood pressure's dropping, we need to send communication to our endothelial cells, and then we need to constrict, that is disrupted completely. And then, when you're laying down, everything should relax. Your blood pressure should be low. And the opposite happens. It's just this crazy phenomenon that happens, this autonomic dysfunction with people with Parkinson's. So typically, autonomic dysfunction can happen with people, with cardiovascular disease, chronic kidney disease. But the separation between these two is whenever, let's say you have untreated hypertension for 20 years, you're going to have oxidative stress and damage to your vessels, and then your vessels don't work. They have a little bit of scar tissue basically on them, and they don't vasodilate and constrict. They're rigid, and of course they don't move, and of course they don't respond. But you don't have that neurotransmitter issue. Well, with people with Parkinson's, that doesn't happen. Like, it actually, the neurotransmitter issue comes first, the autonomic dysfunction, and then the endothelial cells just are not doing anything. And then over time, you can develop atherosclerosis, but it's not like the oxidative damage locally is causing the issue. It's the exact opposite. So to me, if we can get a handle on heart rate variability, and we can really retrain the parasympathetic nervous system, the vagus nerve releases acetylcholine, and that helps put us into the rest and digest system, then our people with Parkinson's are going to sleep better. Their sleep is going to be so much better. Their vessels are going to start communicating and start responding a lot better. They're not going to have the falls with orthostatic hypotension. They're not going to have supine hypertension. If we can fix this communication some way, somehow, then we're going to be able to prevent a lot of issues with falling, and then all the other things that come with autonomic dysfunction. So when you don't have good blood flow, your bladder's not going to empty properly. Your digestive system is going to be at a standstill, and so many people are constipated, which is horrible.
Yeah.
They don't thermoregulate well. They feel horrible, and when your blood pressure is low, you feel awful. Your energy levels are horrible. So you're gonna fix energy. You're going to fix blood pressure regulation. You're gonna fix digestion, or at least attenuate. You may not fix it completely, but bladder issues are gonna be better. All of these things that really affect someone with Parkinson's and their quality of life will really, if we can control the autonomic nervous system, and get them more into that parasympathetic, then that's going to be huge. It's going to be so valuable. So that's really where all of this ended up. It's kind of, you don't understand it until it all happens, but the first study that I didn't get approved for my dissertation helped me open my eyes towards this vascular issue. And the vascular issue helped open my eyes to this autonomic dysfunction issue. So it's just kind of it's really cool how it worked out, even though it was stressful. So yeah, that's how that all happened.
We'll get into details. That's freaking badass. But that's where, when I started going back after talking to you, I think, and really looking at the vasculature literature with blood flow restriction, even just mechanisms, it seemed like there was such a potential avenue, and fairly quick, within a month or so, maybe we could see some adaptive changes, which is really cool. Can you touch base on homocysteine and maybe what levodopa does and why that could be an issue?
Yes, yeah, definitely. So carbidopa levodopa is the drug that is prescribed to individuals who have Parkinson's. And it happens. There's different theories, different neurologists think different things, but really typically within a month to a year of being diagnosed, an individual will be prescribed carbidopa levodopa. So levodopa is a drug that whenever you take it, it's incredibly effective at first, but of course, over time, it's going to wear off and you're going to have to add more and more and more. So someone with Parkinson's disease, they're going to have their medications with them no matter where they go. Because if they don't take them, then they are not going to be able to move. You're almost in a frozen state. You can't move at all. So a lot of people think, the dyskinesia. So what you see Michael J. Fox, where he's swaying, that's a lot of people think that that's Parkinson's disease, but that's actually a side effect of levodopa. So typically around 5 years or so is whenever people start seeing that pretty severe dyskinesia. And again, it's because of the medication, not because of Parkinson's disease itself. So Parkinson's disease is when you're not on levodopa, you have this really slow movement, these stuttered steps, freezing gait, but eventually you just don't move at all. There was a lady I went to visit in her hospital room and they weren't giving her levodopa correctly. And she had just walked a week prior, she had just walked on the treadmill for 30 minutes. And now she couldn't even reach over to get her water to take a drink.
Wow.
I mean, her limbs just wouldn't move. And I was able to explain to the nurse how the timing of this levodopa is so important. So some people take it every 3 hours, every 6 hours. That's typically sometimes every 8 hours, but the longer you have Parkinson's, you're going to take it more regimented and you don't miss that window of time to take it. Otherwise you can't move. So with Parkinson's, there's on and off periods. So what they discovered, and it's kind of funny how things come up and then they get suppressed and no one wants to acknowledge them anymore. But what they discovered is whenever someone takes levodopa, that their homocysteine levels are really high. So they've done studies with people on levodopa and not on levodopa with Parkinson's, and homocysteine is always higher. But if you take it compared to someone who does not have Parkinson's, the people with Parkinson's, even who are not taking the medication, homocysteine is going to be higher. And that comes from that disrupted crosstalk that we were talking about. So basically, whenever someone has high homocysteine, it means there's this homocysteine folate trap, and homocysteine should be converted into folate, and B12 is a big player in that. But whenever you have homocysteine is an important amino acid that our body makes, but when you have high homocysteine levels, it's really damaging. So high homocysteine is linked to cardiovascular disease. The higher it is, the worse it becomes, the worse the probability that you have a cardiac event is really high, the higher your homocysteine levels go. So there's a paper by Hong in 2018 that came out. It said, this is a problem, but there's nothing we can do about it. Like, if you're going to take levodopa, you can move, but your homocysteine is going to be really high. Your risk of cardiovascular disease is going to be high, but there's no way to counteract this. There's no, your option to get off of levodopa is not there unless you don't want to move. And I would say that whenever Parkinson's disease progresses, levodopa has to happen. It's not, I'm not saying levodopa shouldn't happen because of high homocysteine. I'm just saying, is there something that we can do about it? Is there something that we can do to bring down homocysteine levels and allow the vasculature to be healthier and not get as damaged because of the result of the autonomic nervous system disruption? There's something that's not happening where that conversion, and levodopa kind of interferes with that homocysteine folate trap. It comes in, it interferes with that conversion, and that's why homocysteine accumulates. And that's going to damage the vessels because of the drug. So not only do you have the autonomic issue, you also have the drug issue too. And it turns into this issue where you're not seeing good circulation and you're seeing the purple hands. Even we did a transcutaneous oxygen test, which is what you do when someone has a wound and you're deciding whether or not you need to amputate. So they do, you know, the monitors on the skin, and it needs to be a certain level of certain pressure, millimeters of mercury. And then, you know, if it has enough blood flow, the probability of healing is, you know, X. And then if it doesn't, then it's this, and you just make a decision. So a lot of diabetics get this transcutaneous oxygen monitoring test. So we did this test, and there was one guy, I'll never forget it. He had slippers on, and he was laying on the table, and I took off his slipper to put the sensors on, and there was blood everywhere. And I was like, oh my gosh, what happened to your foot? And he was like, what are you talking about? And I said, your big toe, there's a gash this big in it. And what did you do? And he's looking down, he's like, I have no idea, and I can't even feel what you're talking about. So it's crazy. They're literally, diabetic numbers we're right there. You know, people who have mid-range or middle-aged individuals, their blood flow circulation is about the same as the people with Parkinson's that we tested, which is so alarming. No one knows to think of that. But I can tell you there are at least 5 people who've had mosquito bites or injuries, some sort of scratch on the lower leg, and it's taken months to heal. And there's even 2 people who've had to have a wound vac put on because they just won't heal. And they don't have diabetes, they have Parkinson's disease.
Parkinson's.
So yeah,
And these weren't like overly severe Parkinson's disease patients, right?
No,
Dr.
no,
Bane?
and we didn't even take, we didn't even
Mild
take
to
the
moderate.
people, mild to moderate. We didn't even take the severe individuals who are, you know, either wheelchair or bedridden.
These are the people that are in our clinics, you know, for care.
Yep.
You had a great quote from Hong in your deck. It said, basically, we can't treat Parkinson's disease and the vascular disease together. It's kind of a pick your poison, like, okay, get off levodopa and maybe we can fix your vascular, or stay on levodopa and you're going to have this terrible autonomic dysfunction, cardiovascular disease, increased risk of stroke, diabetic-like numbers. And your homocysteine levels that you were picking up in your subjects were really high.
Yeah, they were really, really high. They were much higher than the normal population. And then even with people, when we compare those to people with Parkinson's disease, they were much higher even than them. And whenever we looked at the amount of levodopa they're on way higher levodopa levels. And you know, if you look at I guess I'm trying to be politically correct, maybe some of them see the same few physicians, and it is just that's the in our area, that's probably a limitation of the study too, is everyone is just prescribed more and more and more and more levodopa.
Path of least resistance.
Yeah. And so, you know, no offense to the neurologist, but it is the way that everybody in that area seems to deal with any complaint. You know, I'm not moving as good, I'm falling a little bit more, I have low energy, I'm feeling this, let's up your levodopa. So the amount of levodopa our people were on were so much higher. And so there are studies that I will say that are free from levodopa. Is there still this autonomic dysfunction issue going on? And the answer is yes. But to me, it's just levodopa is adding fuel to the fire and making everything worse. So you're still going to have this issue if you have Parkinson's and you're not on levodopa, but you're probably in the very early stages of Parkinson's if that's the case. There was a study that just came out as well that shows chronotropic incompetence in early stages of Parkinson's disease before levodopa therapy. And they're showing that the heart rate it doesn't get high enough to match the exercise intensity. So their heart rate is not, there's a lot of different definitions of chronotropic incompetence, but their heart rate doesn't get 80 to 85% of the age predicted maximum heart rate. So you're not able to, even if you exposure, this is another thing for BFR, if you expose yourself to high intensity interval training and your heart rate doesn't do what it needs to get the cardiac output that it needs to match, then you're really limited. You're not going to be able to sustain that very long. There's some sort of vascular disruption that can occur as well. Cardiac output, just if you do have chronotropic incompetence with Parkinson's, it's going to limit your exercise ability big time. And that's what they did show that. They showed that as well. So yeah, it is, levodopa is fuel to the fire. But there's going to be a fire anyway. It's just, but it is a necessary drug. So it's not that I am anti-levodopa, not at all. But with that statement, like pick your poison, like you said, that's exactly what the stance is. And a lot of my people with Parkinson's, I ask, hey, can you ask your neurologist or your doctor to test your homocysteine levels? And they just kind of laugh it off. They're like, that was a thing a long time ago. It's not, it's not a thing anymore. That's not going to help you at all. And it's maddening because I'm like, yes, no, we need to fix this. If you're 2, 3, 4, 5 times above what your homocysteine level should be, then we need to look and see what we can do about that. And we need to be very, very proactive in trying to get this under control, because you're going to do so much damage to the vessels, and you're going to have even more digestive issues, even more urinary issues. You're going to have just this huge whirlwind of issues that come with autonomic dysfunction, and it's horrible. To me,
it's a miserable life.
Quality of life. Yes, your whole life. Exactly right. Yep.
And so again, going back to where we started, it's very cool. If you look at your aims, it wasn't, are we going to get the muscle bigger, get the muscle stronger, even though, you looked at some of the functional tests as well, but it was, can we get this sort of vascular tune-up in a short amount of time with a low load BFR? And then the other thing is, we understand exercise is super valuable, and if you can lift heavy and push heavy, do it. But there is, in this population and some older individuals, when you do push heavy, it actually doesn't help the vascular system, and could maybe even worsen it a little bit more. And I remember I was up at Northwestern doing grand rounds, and one of the researchers up there who's kind of the godfather of heavy lifting with Parkinson's people, I kind of ran that by him, and he looked at me cross-eyed a little bit. But it was like, we have to care about all systems here. And so can you go into that a little bit?
Yeah. So this is where you might have to edit some stuff, Kyle. So when I submitted when I submitted the paper, I submitted it to a different journal and fixed everything, for months and months, and felt really good about the end product. But there's one part that I wouldn't take out, and it was arterial stiffness with exposure to high intensity resistance training. And what we saw trends of this happening. So we tested something called reactive hyperemia index, and it shows you occlude the vessel. It's kind of like flow mediated dilation, but you look at it distally, then at the brachial artery. Yeah. So you occlude, and then you have no pulse, and then you release that occlusion, and you see the reactivity of the vessel. So the more healthy a vessel, the more reactive they're going to be. So you're going to get this really strong, big pulse. Well, our people with Parkinson's, it's like you occlude, and then you let go of that occlusion, and it's like so weak and so slow. Well, if there's studies that are acute with high intensity resistance training, it shows that you kind of have this protective mechanism whenever you're exposed to such high shear rates that can kind of damage the vessels. But only acutely do you see a disruption in arterial stiffness. So your vessels are stiff for just a little bit, and then they come back down to normal. And it's showing, and really the conclusion is that whole body, heavy, really heavy resistance exercise can cause this acute issue. And then over time, what's going to happen? So the literature with normal, healthy people is, it's probably not that big of a deal. It's an acute thing. And then you could even see improved vascular
Yeah,
flow
the shear
after.
stress makes it better. Yeah.
Yeah, shear stress makes it better, which is awesome. That's so good. And I love, high intensity resistance training. I think it's amazing. But what I've noticed with people with Parkinson's, working with them on a regular basis is whenever we lift heavy, there's this restless leg syndrome kind of situation that's going on, and their legs hurt so bad. And they don't sleep as well. And there's something with the vasculature that is not happening. But I do believe it's because of autonomic dysfunction. So if you, after you lift, then you have this vasodilatory response that occurs, and you get this muscular pump. You have a lot more blood flow to your legs, a lot more blood flow to your arms, your chest, your back, whatever you've lifted. Your neurotransmitters respond, and they help you go into parasympathetic. And then the way you recover from that exposure, that stressor, that's everything. Recovery is everything. So you want to exposure, you want that physiological disruption, you want that, but you don't have that communication with people with Parkinson's. I mean, for heaven's sakes, when they lay down, their blood pressure's high, and when they stand,
Goes
it's
up.
low.
Yeah, it's the
So like,
reverse.
yeah, so something is so there is, I know in our world, in this like physiology world, especially when it comes to, hypertrophy and, let's even say from the older side, sarcopenia, muscle preservation, um, BFR is amazing, and high intensity resistance training is amazing too. But whenever you have something that prevents you from doing hurt, like, just like if you've had a really bad injury or ACL and you're trying to preserve, that's awesome. But also, if you can't do, so the people with Parkinson's, if they are having limitations of lifting so heavy because of, maybe their motor disruption, but to me, even more, their autonomic nervous system disruption and inability to vasodilate and bring more blood to the area when you're trying to heal and recover. And, you need that muscular protein synthesis to occur after you've lifted. They're not getting that. And so that's what I wouldn't take out. And then the reviewers didn't like that I wouldn't take that little, I cut it down tremendously, but I couldn't cut it all the way, and then it got rejected, and I was so upset. I know it's the name of the game, you just can't. But I'm lucky, I'm so fortunate that we got into the Journal of Parkinson's Disease, because I think that there will be more of a clinical effect, maybe not. Yeah, and I think that people will start to look at autonomic dysfunction, and they'll start to do the peripheral circulation, like the wound healing kind of test. They'll start to do, hopefully, reactive hyperemia, and finally test for homocysteine. We need to know even that correlation, like how much levodopa do I have my person on, and is there homocysteine through the roof? We need to know all of those things. So I'm again, all this crazy stuff, but eventually it ends up as something that is a blessing. And so I'm really happy the way that turned out. But I do have a little chip on my shoulder, and I can tell you, whenever I am plugged in back into an academic institution, I'm going to do a study with arterial stiffness, high intensity resistance training with people with Parkinson's. And I am fairly confident, just from my experience, that we'll see a worsening with arterial stiffness. But we need to see if it's acute or if it's chronic. If it's chronic, that's bad. If it's acute, okay, how can we knock them back into parasympathetic and help with that? So that's
you saw a trend in this study already.
I saw a trend.
So this is your
Right.
4-week pilot.
Yep. If we do it for longer than 4 weeks, is it going to be? Yeah. Even the restless leg syndrome stuff is so interesting, because that's blood flow. They're not getting good blood flow to their legs, and it's very painful. So a lot of our people have that issue, and I noticed that heavy lifting makes it worse.
So your study is the effects of blood flow restriction and resistance training on autonomic and endothelial function in persons with Parkinson's disease. As you mentioned, the Journal of Parkinson's Disease, which is awesome, like you said, that you got it in there. Can you go into your study design? So your subjects, how long, what your interventions were?
Yeah, definitely. So we had a total of 30 individuals that we decided we were going to fill the exercise groups first, and then we were going to do a smaller, however many people we could recruit for the control group. So we were able to fill the high intensity resistance training and then the low intensity resistance training with blood flow restriction group. And I'll just say blood flow restriction and high intensity groups to make it easier.
Yeah.
So we're able to fill those 15 people, and then we had a subgroup of controls with 8 people, and they were asked to just maintain their normal eating and living and not do anything extra. So what we did, we tested for various vascular issues. We took blood for homocysteine, and we were able to really expose that this really is a huge issue. You know, we make the observation, purple hands, all of that, but then when we actually tested it, it's unbelievable, honestly. So heart rate variability was tested, reactive hyperemia index, transcutaneous oxygen monitoring. We did some surveys and things like that, but for this particular paper, it was the vascular and the autonomic dysfunction issues, orthostatic hypotension.
Orthostatic hypo, yeah.
Yeah, yep. And blood, even supine blood pressure, so laying down blood pressure, we were able to test that as well. And and then we exposed these individuals to either the high intensity or blood flow restriction. So high intensity group was the same exact exercises. So they were all seated, which helped to prevent falls and difficulty. Isolated, so anything downstream from the restriction is what we wanted to do. So bicep curls, tricep extensions, leg curls, calf raise, and hand grip. Those, as simple as that sounds. And I like to be really creative with exercise prescriptions. So I'm like, this is the most boring exercise protocol ever.
Safe though.
Yes, safe. Yes, safe. So we
Well, and
did.
also to point out, you really helped control hemodynamics when you did that. Not
Yes,
doing big
100%.
multi-joint
Yeah.
type exercises,
Yeah,
which is
because you think
smart. I mean, people need to think about that when they're always like,
yes.
is this safe for these people?
Yep.
It's like,
Yeah.
well, this is a good way to
Glad you
go
made that
about it.
point because I was
Yeah.
gonna make that if you didn't. Yeah.
Yeah. So you think of whenever you have diaphragmic involvement, so whenever you're lifting heavy, your diaphragm is definitely going to be involved. And whenever you hunker down, do that Valsalva maneuver, in any capacity at all, it's going to skyrocket your blood pressure. So when you're doing leg press, you're going to do that for sure. And is that fine for younger people without autonomic dysfunction? Of course. Yes, like all you know, that's perfectly fine. So yeah, like bigger, even think of chest press too. You hunker down and that diaphragm goes like this, and you are putting a lot of pressure on those vessels, that descending and ascending aorta. Whenever you just move those just a little bit, your blood pressure is going to skyrocket. So there is some element of that whenever you do leg extension, leg curl, but not as much. Not when you have multi-joint, you know, and a lot of abdominal movements have to really, that intra-abdominal pressure has to increase to secure your spine, then your blood pressure is going to go high. So I do think that's really important note for, you know, anyone who has damaged vessels, autonomic dysfunction. I think thinking of exercises that are not incredibly important for that intra-abdominal pressure to increase to support the spine. That's huge. That's really important. So
That was super
luckily
smart.
we were able to control the hemodynamic load, because that is a huge, you know, even with reviewers coming back and forth, like, what about the safety of BFR? You know, talk about the safety, and I think that that's really important. But I can say that, you know, we had 4 weeks with 30 people doing, well, 15 people doing the BFR, and we didn't have one adverse event happen.
Right.
And these are people who already experience really low blood pressures when they just stand up. So
Right.
you know, I was very worried about that. I wrote the protocol, and then I put myself through it, and I was like, oh my gosh. Yeah, I was like,
Yeah.
how can they? But then I forget, like, these people are
So
so
tough.
tough and so
Yeah.
strong, and they have to deal with way harder stuff than how hard exercise is. So like, there were some older, really fragile individuals, and they did amazing. I was just so, it was hard, but they just like the high intensity resistance more than training, more than
Yeah.
the blood flow restriction. It's
Yeah.
just so interesting, but they really did. They're like, ugh, I want to do that other group. I'm like, no. I saw more complaints with high intensity than I did the BFR. And then some of the people in the high intensity group, we let them try BFR after the study was over, and they're like, I like this, which is, it's very painful. I was so worried. I thought, oh no, this is not going to go good. But they did amazing. It was so they
I'm
did it.
so glad you told that story, Annie, because I remember running into you in Abilene. Like I'm standing in line at Starbucks
Yep.
in the grocery store, and I see Annie walk. I'm like, oh, that's Dr. Bane. And so I like randomly stalk her, and she's like, who is this weird guy? And so we get talking, she figures out who I am. And that was one of the things she said, was she was like, I thought we were gonna kill somebody with that protocol. It was
Well,
so tough.
it was 6 rounds of BFR, I
Yeah.
mean, people always
More
ask
heavy.
us like, how much is too much? And we don't know, but I was like, don't let it freak you out. I mean, if you did squat, press, dead, yeah, that's
Yeah.
probably a little much, but I mean, this is a cool way to go about it for
Mhm.
sure. And so your BFR for these 6 exercises, you did bilateral, but did you alternate? I can't remember.
So yeah,
Or
so
did
we
you
did
do,
bilateral, and so it was 60% occlusion, which is, I went the lowest I could go um with still seeing a vascular change. So,
yeah,
what did that look like? So we did 60% occlusion. I think you could work your way up for sure, but we just started at 60. And then after each exercise, then we were able to 3 by 20. Then we are able to deflate and then go to the next exercise. So we deflated, took blood pressures, and then we went to the next exercise. And then it was intermittent occlusion, which I thought it was incredibly effective because they got a break, and they felt like they could get through to the next round. And I will
yeah,
say probably the hardest exercise that anyone experienced was the bicep curl.
yeah.
Out of everything, the bilateral bicep curl, that was probably I mean, I had someone holding 1 pound weights and barely could even lift. I mean, even just lifting your arms at the end of that is so hard.
Yeah. Yeah.
It's incredible. So they were able to all get through it, and I was super impressed, and I was very worried about low blood pressures because of a vasodilatory response after after the entire exercise session. And I will say that our research, our data says that diastolic blood pressure was a little bit lower overall, but we didn't have any sort of like, syncope events or anything like that. We were able to show that you can safely do that. And I would say a big thing though is don't be, if you are working with someone with some sort of autonomic dysfunction issue, especially people with Parkinson's, is let their body reset itself. And that may be it's time for them to take their levodopa medication, or we even had individuals do a lot of water, and we wanted their blood pressure to get back up to where it was before. So if that diastolic blood pressure was just a little bit lower, as a just being overly cautious, we're like, okay, we're going to let that reset and come back up. So I think if you're in a clinical area, then if you could just take blood pressure before and after BFR and make sure that blood pressure is not too low, then that is really to me a precaution that is really important
It's
for
worth the
someone with
time.
Parkinson's. Yeah, with
Yeah.
Parkinson's, because blood pressure, you can't communicate the way you're supposed to. So
Yeah.
just make sure it comes back
Yeah.
up. But we didn't have any issues with that at all. And people were able to finish it. And then the high intensity training was 3 sets of 8 at 80%. And they did the same exact exercises, made sure that they rested in between sets. And yeah, and we just compared the results between those two different exercise stressors, exposures, and the
And
vascular.
just to get the BFR protocol, because people get real excited and ask us exactly what was her protocol.
Yeah,
So
okay,
it
okay.
was 3 rounds of 20 at 20% of a 1 rep max, right?
Uh-huh.
Done bilateral, 30-second rest periods between the sets with the cuff
So
inflated.
So the cuff inflated, yes, 30 seconds in between with the
30
cuff
seconds.
inflated, yeah.
And then a minute plus whatever it took to get to the next exercise
Yes, yeah,
between
that
those sets.
transition,
Okay.
yes.
Okay.
I think
Cool.
it was 90 seconds. I should, yeah, but yeah, a
Yeah.
good,
But
just that
sometimes it takes a
transition.
minute to get to a new machine or something
Yes,
like
that's
that.
right.
Did
Exactly.
you alternate lower and upper? I can't
Mhm,
remember.
yes, yep. So we would
Okay.
do lower, upper, which really
Okay.
seemed to help
That's
as
a
well.
nice break as well. And
Exactly.
here's what's important too. I mean, people get hung up on protocols, which drives me crazy, but follow exactly what everyone says. You know, it's like, well, why didn't she do 30, 15, 15, 15? Why did she use 60%? You know, as long as we're kind of in these ranges, we're
Yes.
probably going to be okay. There's a different way to skin the cat for
Yeah,
everybody.
exactly. I agree with that 100% because I honestly thought that the 30, 15, 15, 15 would be too much.
Mm-hmm.
And so, and I thought, okay, let's just do 3 sets of 20 and then 60%. There was another study that did that, which I didn't just come up with that out of thin air,
Vascular one.
that
Yeah.
had favorable results. But,
Yeah.
and then the 60% occlusion is what's the lowest anyone has gone to see any sort of vascular, positive vascular changes. And I did that just for their ability to tolerate, and me knowing blood pressure might be an issue. That's why I also did 60% occlusion. But you're right. I think that it's so individual. I had some individuals I could have ramped up really fast, but with research, you can't do that. And I had some that we might actually start a little bit lower limb occlusion, and work their way up. But this is just, standard what we did.
Standardized.
And the fact that homocysteine dropped like it did, and that
Well, let's get into that. So
Okay.
homocysteine was the big one. I mean, I encourage everyone to get this paper. Your graphs are pretty impressive when you look at these changes. So homocysteine, let's go into that.
Yeah, so homocysteine improved tremendously, and there's some B vitamin recommendations, and that's what I looked at too. Should I go, because my PhD is also in nutrition, so I thought, should we do supplementation with B vitamins and see what the result is there? But there are some studies that say no change, some studies that show a little bit of change, nothing major. So I wasn't expecting anything big with homocysteine levels, but homocysteine decreased tremendously. And my thought is, so whenever you do high intensity resistance training, and homocysteine with high intensity resistance training was favorable. That's why I chose resistance over cardio. But when you have that crosstalk, that's good. Then those neurotransmitters can actually. Did I do that?
Yeah,
Did you
That's awesome.
it's like when you do the two thumbs up.
Oh, okay.
I don't know. I can't get mine to do it, but
Okay,
awesome.
there you go.
Yeah.
Well, I'm
Sparklers,
excited about it, so
Sparklers
that's
released.
cool.
Yeah.
Okay, so so when homocysteine when it was affected tremendously, and I was really excited about that because it's hard with any supplementation to drop homocysteine, but high intensity resistance training can do that. But you have that crosstalk, so my neurotransmitters are talking to my endothelial cells, and you get a really good vasodilatory response after heavy resistance training. And I think that's where a lot of the favorable things with homocysteine come from, is your ability to do that. I think the difference with the high intensity resistance training and the BFR protocol we did was that crosstalk didn't matter as much, because literally whenever you occlude, you force those vessels to open up. You force that. Your brain is not having a ton to do. So while locally you do have that, nitric oxide that helps with that muscle pump, your neurotransmitters also have a lot to do with what the body and where blood flow is going. Well, you just kind of force it to stay in that area, and you elicit a local response that would not have happened otherwise. So to me, that's the difference is in a lot of people who are pro high intensity resistance training for people with Parkinson's. It's that autonomic dysfunction and that crosstalk with the endothelial cells. That's not a consideration in their mind, because really it hasn't been done before. The homocysteine and blood flow restriction have not been tested before. So to me, we're able to bypass a broken system, and we're able to see the result of what high intensity resistance training should be, but cannot be, because once again, the system doesn't work how it's supposed to.
It really makes me think if it's like a hypoxia thing, if it's just a different kind of signaling cascade that you're tapping into there, because we're able to get so much hypoxia in that limb. That's just kind of where my head goes. But to try to
Hypoxia, but
explain
then
it,
also that artificial physical like swelling that you're creating. I mean, you're almost forcing this vasodilation and allowing some 40% arterial inflow. So you're still getting flow into the limb, causing swelling, and then probably a lot of venous swelling as well with the hypoxia. Yeah.
Yes.
Yeah. So that's impressive. So homocysteine was significantly better from pre to post in BFR, but also way significantly better, it looks like, compared to lift and heavy. If you look at the numbers.
Big time. Yes, that homocysteine was so impressive. And then what we saw with the transcutaneous oxygen monitoring is, you had these diabetic levels. The man with the bloody toe that didn't even realize he had a gash in his toe. They actually with blood flow restriction, it actually improved out of that range to more of a normal range that you would see. So no worry at all about can a mosquito bite heal if you get a mosquito bite, things like. So you were able to see in such a short time a significant improvement in peripheral blood flow, which makes it's all connected. You're not going to separate homocysteine from improved blood flow. So that's another measure that just validates. And then reactive hyperemia index that, when you occlude and you let go, and the reaction was significantly better. And that's what we saw was a little bit worse with the high intensity resistance training, is that reactivity. Yeah. So homocysteine went down a little bit, but that arterial stiffness was indicated not significant. So nothing that we reported, but it trended on the side of perhaps being a concern, maybe with longer exposure than just 4 weeks to high intensity.
It definitely didn't improve where your BFR group did.
Right, it didn't improve. That's right. Yeah. So that was amazing. But you know what I thought is, it's so simple, but blood pressure went from 127 systolic to 113. So to me, the vessels are more relaxed when you're laying down. So that was a supine blood pressure. That's huge. That's what they should be in the first place. So that was only with the blood flow restriction. So the vessels are relaxing, and the heart rate variability was better, which heart rate variability is, are you sympathetic or parasympathetic? Parasympathetic is vasodilated, relaxed vessels. Sympathetic is your vessels are constricted to reroute blood to where they need to go. So it's kind of, it's really, to me, that's such a simple, blood pressure was lower. But how many people try to make blood pressure lower? And all, anyone with hypertension, it's so destructive. And blood flow restriction was able to do that in these people with Parkinson's. Now, to me, I think that if you already have a very diseased vessel, you have that arterial and atherosclerosis and all of that scar tissue, basically that damaged vessel, that probably wouldn't be the case. But with this autonomic dysfunction and this disrupted crosstalk, I think that that's probably why that happened. So that was amazing. And then orthostatic hypotension was significantly better. So whenever these people would stand up, their blood pressure is not plummeting, which is where the concern with the falls, you were so worried about those falls. And I do believe not a majority, I don't want to say that, a large portion of the catastrophic falls with people with Parkinson's are probably due to plummeted blood pressures and falls, and they don't even realize it. Yeah. So I hope that would be on the radar of a lot of neurologists that are seeing people who are falling a lot. Just let's check orthostatic hypotension and try to treat that if we can. So to me, those are the amazing things, is because people experience those on a regular basis, is high when you're laying down, low when you're up. And those actually improve tremendously. So, and everything just goes along with it, the homocysteine and the reactive hyperemia index and transcutaneous oxygen. It's just something favorable is happening with the vessels. And I think it's because the forced vasodilation and that's not reliant on the autonomic nervous system. I think that's what's probably.
Man, you just go back to your quotes where these people are like, I'm sleeping finally, or I just feel so much better in general. When you get out of that autonomic dysfunction, I mean, and again, 4 weeks, it was 12 sessions. So,
Yes.
so straightforward. And this was
Yes.
one of my favorite things that I don't know if it's in the paper, but I think it was in your deck of, look, we're not going to expect people to just be on BFR 365 days a year or all year long, right? But if they can improve motor function, strength, and stuff with lifting heavy, should this be like a once a quarter, once every 6 months BFR 4-week vascular tune-up? See if you
Yes.
can take those homocysteine levels down. See if you can improve the endothelial pliability. It's not hard to do, it doesn't seem.
Yeah, no, that's exactly right. I do think, if I know that insurance and all this
Yeah.
has to be involved, but I do believe the same exact thing is maybe quarterly, and we don't really know that yet, but I would love to explore this next is how long, what's the residual effect of, post BFR, how long does this happen, and then how often would you need to expose someone to BFR? And we know at 4 weeks is effective, and that's
Mhm.
short and sweet and doable. And then, maybe it starts to wear off at, 3 months or whatever, 4 months. I don't really know. But
Yeah.
then you could initiate another BFR session. And I just, it's so doable, and we have shown that it's safe. You would have to, take the precautions like you would anyone, but I think that this opens a whole world with, physical therapy and clinicians. And if
No,
someone
you're
came in and they could, the doctor could approve, wherever state you're in, they could approve this protocol for 4 weeks, and autonomic dysfunction will get better. I
this
mean, it's
needs, if
proven.
anything, needed a Medicare code. That's why I got so excited, when you talked about this, and then when you sent me your dissertation.
Mhm.
Imagine a drug that these individuals could take where we could say it would take their homocysteine levels almost down to a safe range. It would increase the pliability of their endothelium, improve their reactive hyperemia index, help with their orthostatic hypotension. That drug would have massive clinical trials right now.
Yeah, you're right.
Yep.
No, you're
You
exactly
know,
right. And
yeah.
100%.
that's the sad part of a lot of the things that we deal with is,
Yeah.
there's something that's very, very effective. And you're right, it would get a lot more exposure if it was a drug.
And by the way, you're probably going to get stronger because,
Yeah, that's
there
right.
was no difference
Yeah.
between the groups, but they did
Nope.
get stronger,
Yeah,
and so
Right.
it's not like you're going to be down while you're doing this. You are going to get stronger.
that's
I
right.
think when I originally saw your deck, functionally, their 6-minute walk test did get better in the BFR group, I think, right?
Yes, it did.
I don't think that
Yeah.
was in this paper, but
No,
they did
no.
see a
Yeah.
functional improvement.
Yep. Yeah, I have a lot more data too um that I could publish another study, especially quality of life stuff. There was a big
Yeah.
survey that we did. The people who were with high intensity resistance training reported worsening mobility versus the
Yeah.
BFR.
Hmm.
So, which is, when you lift heavy, you kind of feel a little, and then you
I
feel
have that.
better.
True. Yeah.
It's
Yeah.
all of that healing and recovery. But I don't believe that just based on numbers with heart rate variability, they have the ability to heal and recover. That's the beauty behind BFR too, is you don't see that muscular damage
Yeah.
that you do with hurt, and you don't. If you don't have parasympathetic involvement, you're going to stay broken down and you're going to feel awful. But if you
That's a
do,
good
you'll
point.
heal and recover, and it's awesome. And
Yeah.
so I do think there's something big to that, and I need to, I'm determined that I'm gonna expose that, and people won't like it, but it's my observation. If it's for, the good of people with Parkinson's disease, then who cares who you make mad?
Amen. I'm all for lighting things on fire.
Yeah, that's
Well,
right.
I think too, what's always exciting with this is you see like BFR with these healthy populations and you see this little bit of change, but it's like, man, when we apply it to someone who's really atrophic from a orthopedic surgery, I think we got a much higher ceiling lots of times. And so your reactive hyperemia index change in this disease population was like at 50% improvement or something. And
Yes.
the prior study that looked at that was elderly folks
Yep.
without disease, and it was around 16%. So their
Right.
ceiling's just so much higher
It is.
for
It is. And
intervention, I think.
I think the vessels, if you don't have the neurotransmitter crosstalk with the endothelial cells, your vessels just lay dormant and they haven't done anything and they're not responding. And to me, BFR wakes them up. It's just
Yeah.
like it forces them to wake up, which is really awesome without the muscular damage, without perhaps the limited mobility, the acute session, it's hard. It's hard, you know, in and of itself. It's really hard, but afterwards, you don't feel awful. You know,
Yeah.
your body has
Right.
done a lot of things systemically, but it's not like, you know,
Yeah.
you have the joints hurting as much and because you
Yeah.
lifted very
You're
little
good in
weight.
30, 45 minutes. Most people are like, I'm cool. I'm good.
Yep.
Yeah, that's right.
Yeah.
Yeah, that's
Yeah.
right. Exactly.
Well, we need to get a Michael J. Fox grant or NIH grant and get these multi-center longitudinal trials
Yes.
with this protocol, Annie.
That
I
would
think
be
it's
awesome.
Yes,
huge. Yeah.
that would be amazing. There's a study in Colorado that was approved by the Davis Finney Foundation. They're a pretty big organization too, and they approved the guy in Colorado, I forget his name, but he's doing a BFR study with people with advanced Parkinson's disease. And so
Oh,
I just wonder how that's going to be with, you know, them, the ability for them to tolerate it. And he's not looking at autonomic issues and vascular stuff like I did. He's looking at motor stuff.
okay.
So it's interesting to see. Well, I'm very interested to see what he comes
Is
up
that
with.
at the University of Colorado?
I think so. I
Okay.
think so.
We have a
Yeah.
MS trial going on there right now. It's
Oh,
funded
okay, cool.
through the VA. Yeah.
Oh,
So I
neat.
wonder, I'll talk to those guys. I wonder if it's
Yeah.
in group.
Yeah, that's awesome. That's
Annie,
really
Annie, I'm curious. And I know you said you don't know, so you can obviously answer. I have no clue, Kyle, to this question, but I am just kind of curious. Since you kept, you know, kind of working with these folks after the fact, do you have an inkling of like how long the effects of doing this study lasted for people? Do you have any sort of intuition there?
um I would say because after we did the study, then COVID hit and then, you know, it shut down for a year and then people came back. And I would say on an individual basis, I've done blood flow restriction with people I know have really terrible peripheral blood flow. And so I'd say individually, not from a study perspective, because I'm not sure, you know, I could say overall, but from an individual perspective, I think that it does vary. But I also think people who are more advanced with their Parkinson's need more exposure to BFR because they're not able to. There are some people who do the BFR, I think it wakes the vessels up, and then they're able to do higher intensity, you know, with cardio, they're in more shape, they can lift a little bit heavier. I think that their ability to do more helps to sustain that level, if that makes sense. But people with advanced stages of Parkinson's disease, I think that they would need more exposure. So there's, you know, a rating system. We use the modified Han and Yar system. So I would say people who are stages probably 3.5, 4 need more exposure to BFR. So I would say I don't know for sure, but my guess would be, you know, probably 8 weeks, you know, exposure some ways, maybe 12 weeks. And the people who are capable of doing more, not as much.
Cool.
Well, man, this is awesome. I'm glad this paper finally came out
Me too.
through the pandemic,
Yes.
through everything else. So congrats. This
Thank
is
you.
groundbreaking. I really hope the word starts to get out there and people look at it because it's not only valuable for us in rehab, but I think it's valuable just for the medical community to even understand what's going on with the vasculature, and there could be something that would be an intervention.
Yes,
Yeah.
amen. I think this needs to be on the radar and stop ignoring homocysteines, you know, start looking at blood flow. It's not just about motor symptoms. So yeah, you're exactly right. And BFR it was able to combat the thing that Hong said was inevitable, you know, pick your poison. You don't have
Yeah,
to do that. If you can do BFR, there's major potential for improvement in these things that seem to be inevitable.
very, very awesome. Well,
I thank
Dr.
you for
Bane,
the physiology lesson. I think a lot of
yeah,
people
I
are going to listen
know.
to this
I
and go
know.
back and listen to it again and be like, oh, this is great. This is really, I understand better what's going on in the system. So I think that's huge. So
Awesome. Thank you guys for having me.
You're amazing, Annie.
I appreciate our connection, and it's been a long road, but it's been awesome. So thank you so much.
Absolutely.
Congrats.
Thanks for listening to the Owens Recovery Science podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before we get out of here. First, want to say a sincere thank you for listening all the way through, but also wanted to remind you that this podcast should not be considered medical advice. It is strictly entertainment. It's a way for us to try to keep up with what is ongoing within the BFR world. If you require some sort of medical attention, medical advice, please seek that from a licensed individual within your state. Thanks, and we'll talk to you soon.